Welcome to BrainSTEM, the podcast for anyone curious about the brain development, and brain disorders. I'm your host, Dr. Hilary Marusak. In this really exciting two-part series, we're tackling one of the most common and often misunderstood mental disorders, depression. Today in part one, we're starting with a powerful personal story. I'm joined by Amanda Geisinger, who is here to share her lived experience with depression, the highs, the lows, and the moments in between. And then stay tuned for part two, where we'll be joined by an expert in the neuroscience and treatment of depression to explore what's happening in the brain and what the science says about the best paths to recovery. So be sure to stick with us for both parts of the episode. Amanda, thanks so much for being here and for your openness and sharing your story. I so appreciate it.
Oh, thanks for having me. I've been looking forward to talking to you.
Awesome. Likewise. Can you first just start by telling us when you first realized you were struggling with depression? Like, take us back to that time.
It was pretty early, pretty young, but I had a totally normal, happy childhood. And then sort of out of nowhere when I was 13 was probably when it started. But I didn't have language for it. Like, I didn't know that mental illness was a thing. So I didn't really realize at the time that what was happening probably shouldn't have been happening. But when I look back on it, right, if I'm sitting on my bed in the middle of the night wishing I was dead, like, I was depressed. That's depression.
Yeah.
And but I didn't have anyone in my life at the time who believed mental illness was real.
So common, unfortunately.
So I was not diagnosed. That's why I had to piece it together in hindsight. And it was pretty intense. Like, it was the suicidality was actually my primary symptom. It was just like wanting to die all the time. And it was very physical, which I think is not something I hear people talk about a lot. But I had like the most similar feeling to it is actually a craving. Like, I like had a physical urge for self-violence. And I experienced it really profoundly when I took lithium, which is, they give it specifically for suicidality. And as soon as it hit the appropriate concentration in my bloodstream, I was like, holy cow, this was like a physical thing. I was like, this is wild. But also it was like sort of the suicide the way that you normally hear of it too, which is just that, like, you're in so much mental pain for so long and it's so severe that, like, you just want it to stop. And like, you get to a point where you're desperate and like, extreme things make sense in the context of extreme pain. And I also had like a compulsive aspect to it too. Like, I would call it like the soundtrack to my life was like these compulsive thoughts that just played in the background. Like, I wish I was dead. I wish I was dead. Everybody else would be better off if I was dead. Like, I shouldn't be here. Like, this is not worth it. Like, all the time. Like, fortunately, there was still a voice that I had control of, that I had alongside of that.
Yeah.
But that was rough. And then I mentioned the mental pain. Like, that was probably the mood part. Like, I was just sad, deeply despair, I would say, was my resting state. A lot of people have variations, but I never got breaks. Like, it never like went, like, it was always there. Like, I didn't have any other emotions at all. Like, no happiness, no like peace. But I didn't have the bad ones either. Like, I didn't have anxiety or anger. But it was like to the extent that even all of my dreams were nightmares. Like, there was just it was like locked in. And then there's sort of like some of the other normal stuff too. Like, it's sort of everything that comes into your head sort of runs through this filter that turns it negative, right? Like, so if someone says something kind to me or about me, I'll hear it like, oh, they're just being nice. You really suck, right? Like, that's how it translates. If I want to, then I have to like purposefully be like, that's probably not true. It's just your brain auto-interpreting the situation. And then there was no pleasure in anything. Like nothing felt good. Nothing was interesting. Nothing was engaging. It was like, maybe a good analogy is like, it was having the wind in your face in all areas of life. Because
Yeah.
I don't think we realize how much we rely on our emotions for motivation, like
Hmm.
to do things. And like, I didn't want to do anything. And I didn't, like, everything was hard.
Hmm.
So I had to like build myself a strategy to function.
Hmm.
So on the good days, it was if I were the person I wanted to be, what would I do right now? Most of the time, it was, this could suck a lot worse if I don't do something. What should I do? That was
Yeah.
my other.
You had to like pump yourself up almost. Oh
Yeah.
my gosh.
And so it was intense. Like, I'm not sure how I survived into adulthood, honestly. I
Oh
don't
my
know.
gosh.
Looking back, I don't know how that happened.
Especially as you're saying, like a 13-year-old, like that must have been so confusing. And I can't even imagine how terrible that must have felt. I mean, you said you first noticed around 13. Do you think it was like a gradual thing that at 13 you were like, okay, something is going on? Or was it kind of always present before that?
I don't think it was really present before that because it life suddenly became super negative at that point.
Yeah.
And I just found ways to blame it on myself. Like, I thought I was doing it. I thought I was causing it. Like, it never occurred to me that it might not be my fault in
Right.
some way.
Yeah.
Like,
Which is definitely a form of self stigma, right? Like, why can't I just snap out of it? And it's a brain disorder we'll get to. But yeah, I mean, what you're saying is I've heard so many times too, and it's quite common, and the data support this, that a lot of mental disorders, including depression, begin during the teenage years, which there's so much flux in your brain and your body and your hormone levels with puberty happening that we really think of it as being kind of a vulnerable period for something like depression to happen. And it sounds like that's the case here too.
yeah.
Definitely. And I love how you painted a picture of just like the different aspects of depression, because it wasn't only the suicidal thoughts, which sound absolutely terrible, but also you mentioned like the amotivation or the lack of motivation, the anhedonia, what we call in psychiatry, like the lack of um, getting pleasure out of things you typically would. And you also mentioned that you didn't have like the anxiety aspect, which a lot of people certainly have. Did you have any more like sleep problems, any kind of like physiological difficulties, feeding behaviors, any of those aspects?
My sleep, I had sort of the typical, like, you wake up way too early. Like, I would wake up naturally at 3 a.m. every day,
Wow.
no matter what time I went to bed. Like, if I went to bed at 12, I'd wake up 3 hours later.
Wow.
Um, and I also had, so I didn't realize it at the time, but when it got better, I also was able to realize that I was like slower. It was like my whole brain was just in slow motion, kind of.
Hmm.
And like my thoughts worked slower. They were harder to access. It took more effort just to think.
Yeah.
Um, and so things happen for me in my brain much more quickly and fluidly now that it's not there. I
Hmm.
noticed that difference. And also energy. I was like fatigued a lot.
Yeah, I can't imagine for sure. And how did this show up in your life, and how did it affect, your ability to go to school, to have friendships, family
I
life?
turned extremely inward. Like, I didn't
Yeah.
talk to people about it, and I didn't talk to anybody about it. And because I was so turned inward, I had a hard time making friends, obviously. So I didn't have a lot of close friends. In middle school, I started to sort of make some friends in high school, but they didn't know. I didn't tell them about it. And college, I think by college, I still hadn't had a diagnosis or been evaluated, but I
Wow.
think I knew at that point, definitely by that point, that something was wrong.
Right.
And so my college friends sort of knew what was going on, but they also didn't have the language or the knowledge or
No.
the like. It never occurred to them to say, hey, maybe you should go to a therapist. Like, it just didn't, I don't know, it wasn't part of our reality.
Yeah. So incredibly common to hear that. And it must have been so isolating too, just to experience that for so long.
Yeah. My
Maybe like,
saving grace was that I'm able to focus. Like, that's like maybe a rare skill to have nowadays. But like, I'm very good at focusing my attention even on things I don't want to do and for extended periods of time. And I
yeah,
think that's what allowed me to be so functional. Like,
yeah,
I had the ability to just like force myself through a lot of things, and that's how I made it through school. I made it through art school. And so I managed to survive even though it was difficult.
yeah. I think that's kind of a beautiful silver lining too. And you keep alluding to kind of your recovery journey, and I know like that's a whole, that's a whole adventure and story in and of itself. But could you summarize like how you got from that point, from being in college still, not having that diagnosis to where you are today, maybe, so folks can hear?
Yeah, it's a good story in hindsight, but good stories are sometimes hard to live through, you know.
I'm sure.
Um, so I started. So it was after college. I moved to New York City, and I made some friends here, which I was very very fortunate. And they were the first ones that were like, "Hey, like." You're not okay. Like, you should see a therapist. And that was the first time I had ever considered even the idea of a therapist. And I was like, oh, okay, I'll try it. And so I started therapy, and this therapist immediately referred me to a psychiatrist also.
Mhm.
So I was doing that. And so I started with medications. And over the course of I would say 15 years of treatment, I tried 21 different antidepressants.
Wow.
Yeah, I checked all those boxes.
Yeah,
I've done every
good.
kind there is. And then that obviously wasn't going so well. So I did TMS, which is the
Mhm.
transcranial magnetic stimulation. I did one round, which is like 30 some sessions. And it actually helped a tiny bit with the compulsive thoughts. Like, they slowed down a little bit. They weren't as loud and as intense and as frequent. So they were like, oh, it did something for you. Let's do another round. So
Mhm.
I did another 30 some sessions. Um, the bummer is that like a lot of this stuff, because it's mental health stuff, and I'm sure you've heard it this before, but like, no insurance coverage. Like, so it was really, really good that I was able to hold down a job, because I would not. I mean, I had a great job, and I still had insurance that wouldn't cover any of my mental health treatment and therapy, like,
Wow.
or the TMS or whatever. But so the TMS helped a tiny bit, but not enough.
Mhm.
So the next step was ketamine. And I did IV infusions of ketamine. So I would go like once a month or so for, I think, 2 years. That was rough. And I wonder if it was the mood thing. Like, all of my trips were bad trips. Like, it was a
Mhm.
nightmare. Like, every time. It was like being in a nightmare, but being awake.
Oh,
Because
no.
it's like a hallucinogen, right? It like sort of distorts reality in a way that's frightening if you're already upset. Most people enjoy it though. So if ketamine's an option for you, don't let me scare you off. But I had a bad
Yeah,
experience with it.
sure.
Um, Helped a tiny bit, but not enough to keep doing, and then eventually stopped helping at all.
Mhm.
So then we carry on. We carry on to ECT. And ECT is electroconvulsive therapy. And it's the way they do it is like an outpatient surgical procedure. So you go to the hospital 3 times a week, and you go through the whole outpatient process. You get general anesthesia, they knock you out, and then they shoot electricity through your brain. It induces a seizure. The seizure somehow makes you feel a little
Mhm.
better. My understanding is it's still no one knows why.
Very
And then
mysterious, yeah.
you wake up and you carry on with life. But it's obviously incredibly disruptive, right? Because I had to do it. I mean, I was fortunate that I just happened to not be working at the time, but surgery 3 times a week is, it's a lot.
For sure.
And unfortunately, this was also a little bit helpful. And in hindsight, I wish that it hadn't helped at all because I would have stopped sooner. I did it 40 rounds of it.
Wow.
Which is a lot.
Yeah, that's a tremendous amount.
Yeah. And so the memory damage became a thing. I got to the point where I couldn't remember where my sock drawer was. Like if I wanted to wear socks, I had to open every single drawer in my dresser to see which one had which things in it. And I didn't remember what subway stations were a block from my apartment.
Wow.
I had been using this software every day for like 10 years. I opened it up. I had no idea what any of the buttons did.
Wow.
And I was like, this is not worth the small amount of relief that I'm getting from this.
I just want to underscore too, like what you're talking about, these are invasive treatments for people with treatment-resistant depression, which is clearly, if you're saying you've tried 21 different antidepressants, this is the next available and they are FDA approved. But yeah, they are no joke with the side effects. So just wanted to mention that.
Yeah. Fortunately, no one starts you there.
Right. Right.
The ECT is, you have to earn your way to ECT.
Yeah.
And then eventually I stopped just because I couldn't keep going. And then somehow, I can't believe I really made it that far before my first suicide attempt. Well, first and only suicide attempt. I attempted to end my life and then ended up in the hospital, 12 weeks inpatient. That's the point in time where they sit you down and they're like, you've done everything that's legal. There's nothing left, like literally nothing left. You've tried everything. And so come back when you need us again. That's what they said to me when they released me. They're like,
how did that feel? They were just like,
I was hopeless. I was like, I'm going to die. Like, it's not going to be that long before I attempt again. Like, because I can't keep living like this. It's just not, I just felt like I had lost all mental strength that I had left. Like, the endurance just had, like, totally evaporated. Like, I had ground myself into a pulp trying to survive. And there just was, like, no juice left to run on. And I don't know why I kept trying, but I did. And so I had heard somehow that Mount Sinai, which is a hospital near me, has a treatment-resistant depression program. And I was like, oh, I'm going to impress these people. And so I talked to them, and they did a super thorough evaluation. And at the end, they were like, wow, you really have tried everything. And I was like, I don't know if I feel proud or despondent right now.
Yeah, right.
And then they said, but there's another team in this same hospital that is running a clinical trial for treatment-resistant depression. And they have one slot left. And how do you feel about an experimental brain implant? And I was like, I got nothing to lose, right? Like, best case scenario, I die here, right? Sign me up. And so they passed me along to the DBS team. DBS is deep brain stimulation. And there are a ton of inclusion and exclusion criteria for it at this point because it is a clinical trial and it is a brain implant. So they're very, very, very careful about who they will do it for and in what circumstances. But I made it through all the hoops, and it really wasn't that long after I talked to them that I got the surgery. And DBS is like, it's kind of like a pacemaker. So you've got like this thing in your chest that's like the main computer part. And then it's hooked up to a wire, and the wire goes up the side of your head and down up to the top of your head. And then it splits into two leads that go down into your brain, and they have like little chips on them. They're not kidding about the deep part. It is like down behind your eyes. Like it's really in there.
Yeah.
And So the day after the surgery, they turn it on. And 5 days later, every single symptom disappeared. Like,
Wow.
it was almost instant. It was like thoroughly disorienting. It was like I'm like in someone else's body on a different planet. Like I was like, I don't even know what reality is right now. Like this is so different from the life that I have experienced. And the relief obviously is like beyond words. Like just such a visceral, like, oh my gosh, it's over. It's like, wow. To just not be in distress all the time.
I mean, disorienting is the best word for it, like you said.
Yeah.
So we had your friend John Nelson on, and he said the same thing. And it's just so like, as you were talking too, I was just thinking like part of the problem with treatment-resistant depression is, if you started at 13 experiencing symptoms and then you're not being treated until, what did you say, after college? Like that's years
21,
and years.
22.
21, 22. That's years and years of your brain getting into the same patterns. And we know that that repetitive brain patterns kind of solidify themselves in these neural connections. So you are like fighting an uphill battle to undo all of that. And to have a treatment that works like this is incredible to undo all of that. That must have been such an adjustment. What happened after? How did you feel?
I would say the first 6 months was just disorientation. Like the first time I felt anxiety, for example, I was like, this is stupid. I don't do this. Like, and anger, I was like, oh, I kind of get the appeal of anger. This one's a little fun. Like test driving all of your emotions for the first time as an adult is an experience.
Oh my gosh.
And then there are like ones that I hadn't thought about, like compassion. I started feeling like, I was like, wait a second. You guys help people and you get good feelings for it? I was like, I've been getting cheated in this whole humanity thing, right? Like, I've just been being nice because it's the thing to do, right? Like, now I know you guys.
Wow.
But I think shortly after the surgery, my brother got married, and I had an appointment with my psychiatrist like a week later. And I was like, like, people have always said, like, I'm so happy for you. And I was like, I didn't know they meant that literally. I thought that was just like something people said when to be nice. Like
going through the motions.
I was like, I was at my brother's wedding and I was literally happy for him. I was like, oh, it's a thing. Like, so there was a lot of just like, oh, this is how the world works in that period. And then the trial, my version was very mercifully designed to get around the placebo condition. Mm-hmm. So there is a point where they're like, okay, 50-50 shot. We shut the device back off for a couple weeks. Mm-hmm. And I lost the dice roll. I had it turned back off. I had a little down, but they watch you very carefully, obviously, and they take care of you. And then they turned it back on, and I recovered quickly. That was interesting because the first time they turn it on, you don't feel it. Yeah. But the second time they turned it on, I felt electricity in my brain. I have never felt anything like that. It was wild. That's crazy. And but normally you don't feel anything like day to day. Like there's no like I don't feel the stuff happening in my brain.
It's a pacemaker, yeah.
Yeah. And then so after that, then they're like, you have the options, it's optional. Do you want to get off all the psych meds you're on? Because I was still on 5 antidepressants at the time. One of which was lithium that I mentioned earlier. And lithium is no joke. Like I had bad side effects for every medication I took. I'm just like that kind of person. I guess my body doesn't like drugs. But everyone, as far as I know, gets hit with something from lithium. And I lost my sense of balance. Like I couldn't go up and down stairs without like clinging to the railing and like going really slow so I didn't fall over. And I shook really bad. Like I had to relearn how to hold a pencil, like because my hands would shake so much. So I was like, yeah, get me off of this nonsense, right? Like, but antidepressant withdrawal is no joke, man. Like, especially after you've been on them for like an extremely long period of time. So I was like, it was like having the flu for a year and a half. Like it took me a year and a half to get off, and I was so sick the entire time. But then that wrapped up, and I was like, oh wow, okay, I'm like normal now. Okay, I like have had enough time to understand how the world works, and I'm no longer extremely sick. Okay, let's figure this out now, right? And I finally felt like this was like maybe 6 months ago, even not that long ago. I was like, okay, let's what now that I enjoy things, what are the things I enjoy? What do I want to be doing? What matters to me? What I could start to figure out what I actually wanted from life for the first time instead of just trying to survive life. And the other interesting piece was, and this is probably like this is unique to having been depressed since you were a kid consistently, but I have a personality now that I have not had since I was a kid, right? Because I just withdrew inside myself to survive. Yeah. And I thought that was me. Like, I thought I was just like a withdrawn person who didn't emote or like feel strongly about anything, or like I thought I thought I had kind of a dud personality.
Oh my gosh.
But then I started being in the world without any coping mechanisms. And it was a little scary. I was like, what if I don't like this person that's coming out of my mouth now? I'm like, it's literally like meeting myself as an adult for the first time. Wow. It's like, wow, I talk too much. I don't know if I like this person.
Oh my god!
And I've suddenly become the office comedian. I'm like really curious if my coworkers have noticed that I rack up the haha emojis on Slack now like nobody's business.
Oh my god.
And I was like, where did this person come from? I mean, that's kind of fun, but like it was never me.
Oh my gosh, Amanda. I mean, thank you so much for sharing your journey. And I'm so glad that it has a beautiful ending. I mean, there's so many aspects I want to dig into. I feel like we need like a 10-hour podcast, but I mean, you are like living evidence that depression is a brain disorder, because if you correct the circuitries and the electricity and the neurotransmission, you have instant relief and everything is solved, which is just, it's a beautiful story. And then I also want to just underscore that like you went through everything that modern medicine has to offer right to the very end.
Yeah.
And what ended up being a relief to you was an experimental clinical trial based on, Mount Sinai, which is one of our top research institutions. And, I'd be remiss if I didn't mention right now that these institutions that are saving people's lives and pushing the science are being under attack. And we recently had a podcast episode about this, but I mean, from what it sounds like, it saved your life. And we as a society need to be investing and making sure that these studies and these trials move forward, because that is the future. And just the amount of resources it must have gone into to get you to have brain surgery, experimental, like
this was the only time I didn't pay for my own medical treatment, and I would not have been able to afford it. Should I
don't think anyone, very few people would.
But it's a 10-year trial. So I was like, I emailed my team at one point. I was like, are you guys concerned about money right now? Like, should I be worried about this thing that's now in my body about it being maintained? And they were like, we're okay for your trial. Don't worry. We'll take care of you. But we are concerned about the future, obviously. So
for sure. I mean, there's
been hard
so
to watch.
It's really heartbreaking. I mean, not just in the psychiatry space, but for cancer trials where people are in the same boat, they're on their last line treatments. It's really disheartening. So I think as a society, we need to be investing in saving Amanda's. Like you are living proof of that. So I just wanted to mention that. So you hit on a lot of my questions I had for you, but talking about challenges, I heard you mention like the financial piece that you had to pay out of pocket for all of these treatments, even though, like you said, you held down a job. The stigma component, you had so much of the self stigma. Some of your friends early on didn't know quite what it was. Maybe they didn't have the right words, and I can't imagine that's such an awkward conversation for people to say, but that aspect too, that there's a societal, no one wants to talk about it. What other challenges have you faced, or would you say that people with depression face?
So the stigma one for me is really interesting because I feel like I've seen it change a lot over the time that I've had depression. Because I was like in this for 23 years. I'm like a pro at being depressed at this point, right? Like, let me tell you some history. And it's like, so like when I was younger, the way that people talked about depression was like, oh, like they're a crazy person. It was very judgmental, very derogatory, very like openly hostile to the fact that you were suffering and you shouldn't be. Like this is all like very blamey, you know? And but then over the years, like we've seen incredible changes in how society talks about mental health, right? Like everybody it's in the water now, right? And I think that's partly good because I feel like 13-year-old Amanda would be much more likely to meet someone who knew what was going on and could have helped her.
Mhm.
But as someone who has experienced like a more severe form of mental illness, the new conversation I actually might think I find harder because now that these words are in the drinking water, like everyone has an experience that they attach to the word depression now. They relate to it. And depression is so vague. Like it doesn't mean anything. If you just say the word depression, like depression can be anything from like, oh, like the way people use it, right? It could be like, oh, my favorite football team lost last night. I'm so depressed.
Right.
So like, oh, I'm having constant compulsive thoughts of dying, right? Like that's a big spectrum, right?
Sure.
And but I don't think people are aware of the spectrum, right? So when I try to talk to people about my experience, very quickly I get, oh, I totally get that. I know what depression is. And I'm like, but do you? And it's surprisingly difficult to dislodge people's current understanding of what they think it is. Like, it's, I had this theory. I've done a lot of casual social experiments with this. So I was like, maybe if I lead with the brain implant, like maybe that then they'll get that what follows is maybe kind of hard to relate to, you know?
Yeah, yeah.
Doesn't work. So I have these all the
Really?
time. I have these ridiculous conversations where I'll be like, oh yeah, I've like literally been in a padded room. I had a brain implant. I've been in extended psychiatric hospitalization. And then the person will say to me, oh, I totally get it. Sometimes I feel really sad and I need an edible, but then I feel better in the morning. And it's so bizarre. It's like,
Yeah.
and the feeling that you have when you walk away from those conversations is that you're invisible. Like, and that for me, I think is why I think it's harder than the old version of stigma. Like, I would rather you see me and think I'm dumb than like not see me at all, you know?
Wow.
It's like I'm like sort of trying to have to explain that my reality is a reality. Is it really, really surprisingly difficult? So that's something I don't know that I have the answer for how to do it well. I'm still casually doing social experiments.
No. Oh my gosh. Oh, thank you for painting that picture. I haven't heard that aspect of it before. I mean, we do hear the same kind of thing in PTSD and trauma. Like people will say, "Oh yeah, I'm so traumatized by this." And so the colloquial use of it has kind of lost all meaning, as you're saying. But what you just said was so powerful that it actually makes you feel invisible. And I think that's such a disservice. And you actually said it's worse than the opposite. So I think we as a society need to figure out how to keep moving forward. And, like you said, you've been in this for 20 years. So I know it's going to continue to evolve, but I think we just need to do so much better on so many levels.
It's coming from a good place now, though, right? Like people are trying to empathize, right? Like that's what's happening there. They're trying to like understand what you went through by connecting it to something they went through, but they can't make the step of differentiating somehow. So we're like, it's more of an education education problem maybe at this point than it is like an attitude problem.
That's interesting. Yeah, I mean, it intersects too. And again, should have like a 10-hour podcast, but with the broader conversation about like social media and people self-diagnosing with, all these things on social media and thinking they have anxiety and whatever and some random disease. But
oh my gosh, all the advice around mental health. I was like, if you actually have a mental health disease, this is incorrect medical advice. Like this isn't like
dangerous.
I don't think you realize the territory you're in here with this like casual, like just take a dance class, social media post. Like,
and again, it's so hard, like you said, because they mean well and they're trying to relate. And I do appreciate that it's making people more open about it, but it can be very, detrimental to get your medical advice from TikTok. So please don't do that. See a professional.
I wish there were different words, like, like we could have different language.
Yeah. Yeah, that's something we should definitely continue to think about. What do you recommend for people that are, obviously what worked for you ended up being kind of the most experimental and kind of extreme, if you don't mind me saying, but like, what would you say to someone about like medication, lifestyle changes, other approaches? Like, would you suggest they try different things to see what works for them, or what's your approach to it?
So I've talked to the study team, and like one of the things that they're interested in is like why some people recover better than others, obviously, right? Like they're trying to study this phenomenon. And one of their theories is that like even though I had such a profoundly extreme case, that I recovered very, very well and very quickly. And they think one of the things that contributed to that is just my willingness to try new things, to like try not just like things to do, but like ideas even. Like if there's a new perspective, I'm willing to consider a different perspective. I'm willing to consider that the world is like not maybe what I thought it was. And so I'm just open to trying things. And I think that's like it rings true, right? Like, and so I would just encourage people like, be open to trying things. Like none of this stuff is permanent as long as you stay away from the extreme end of the treatment scale, right? Like you can, I mean, maybe I'll make some lifestyle adjustments, right? Like maybe you try like getting out with your friends more often. And if it's too difficult, like you adjust. Those aren't like permanent things, right? And if you try a medication and you hate it, stop. Try a different one, right? Like you're not committing to something forever. Just like, and so I feel like it's low stakes, right? Like if your options are like suffering versus maybe doing something mildly unpleasant for a little bit, like I would advise the mildly unpleasant.
Yeah. I think that's beautiful. And I'm kind of want to give you one of the last words. So what would you say to someone struggling with depression in addition to what you just said? And also I'd love to hear, what do you say, or what would you recommend to someone who has loved ones, maybe friends or family members who might be in, where you were when you were in your 20s or even earlier?
I would say one of the hardest things for me was affirmation, but like not affirmation that it was a disease. Because I spent so much of my journey blaming myself for what I was going through. And it went away, and I was like, holy cow, none of this was my fault. Like, I did nothing to contribute to my recovery. It's just like, I'm a normal human being now because my brain works the way it's supposed to work. So if you have depression and you have a diagnosis, like, I would just encourage you to, like, consider that you have a disease, like, and not to beat yourself up about that. Right? Like you have a thing that's fixable and you can like go and fix it. Like, and I guess for the families of people with depression, I've been thinking a lot about like the conversations I had while I was depressed. And I've been thinking about what that means for how we talk to people who are suffering. because I was like, I can't be angry about how the world treated me if I don't know why I'm angry about that. And I think what's difficult is that our instinct, myself included, when you talk to someone who's struggling, is your instinct is to fix it. You want them to get better, right? And so you're like, you try to find, you make suggestions. You're like, have you tried this? Have you tried that? Like, what if you just thought about it this way? And that was really made it worse, right? Because it reinforced that, like, this is my fault. I'm not trying hard enough.
No.
I'm not doing enough to make this go away. Every one of those suggestions was actually just a judgment. Like, it wasn't, nothing that anyone ever suggested to me was helpful at all.
Wow.
And so I would just encourage you to, instead of judging, you're not trying to judge. Instead of
Suggesting, but yeah.
If it is a disease, you're not going to fix the disease with your words.
Right.
Right. So I would just encourage you to listen, to be there, and to like try to understand, because as someone who is depressed, it's hard to feel understood, right? Like, that's a valuable gift you can give someone, to like ask them questions, to be like, what are you going through?
Yeah.
And if you don't know how to help, how can I help is like a perfectly valid question, right? Like, talking about talking, I'm into that. I'm like, hey, do you actually want to talk about this right now? That's another really useful one.
Yeah.
But yeah, I would say less fixing, more just being present.
Thank you. That was incredibly insightful. And Amanda, I just want to thank you so much for sharing your incredible story. Your honesty and vulnerability will absolutely help others feel less alone. I already feel like I've learned so much in this conversation. So thank you so much. And then just to our listeners, this is just the beginning of the conversation. In part 2, we'll be talking with an expert in the field of depression to dive more into the brain science behind it, and then get into some of the more current evidence-based treatments, and then some more experimental coming down the line. We'll also tackle some more common myths and questions about depression. So make sure to follow us or subscribe so you don't miss it. And then Amanda, just before we go, is there anything else you'd like to share? Any resources or social media where people can connect with you or that you would recommend?
I don't know that I've found a lot of help on the internet. It's a dangerous place.
End of story.
I'd be hesitant to send people into the mental health world unsupervised. So no, I don't actually.
As we've been chatting with, I think that's a great take-home message. So thank you so much, Amanda. This was a real pleasure. I so appreciate you.
Thank you. And I can't wait to hear the second half.
Now, for the second part of the episode, we are joined by Dr. Ignacio Saez, Associate Professor of Neuroscience, Neurosurgery, and Neurology, all the N's, at Icahn School of Medicine at Mount Sinai, where he directs the Human Neurophysiology Laboratory. Ignacio and I actually met through One Mind, which is a leading mental health nonprofit that, since 2005, has awarded competitive Rising Star grants to early career neuroscientists pursuing high-risk, high-reward research on psychiatric disorders. Ignacio was a 2023 One Mind Rising Star awardee. Congratulations. And I was an awardee the following year, so we're back-to-back cohorts. This really feels like it's more of a family reunion today. Ignacio's lab uses really extraordinary techniques that I'm so excited to talk to you about, recording electrical and chemical activity directly from the living human brain to understand how our brains make decisions, process reward, and regulate mood, and how those systems can go awry in depression, which is what we're talking about today. So, Ignacio, so glad to have you here.
Oh, thank you so much for having me. It's a pleasure, and congratulations to you too. It was great meeting you at One Mind.
I know. I hope we can meet again this fall. Fingers crossed.
Hopefully so. Yeah.
Yeah, I am so excited to chat with you about your research, and your lab does something that a lot of people have never heard of. You actually record electrical activity directly from a living brain during surgery. So can you first start by just painting a picture of what actually looks like, and why would you do it that way?
Yeah, it sounds a little bit like science fiction, right? The notion that we can open up someone's head and put electrodes and record electrical activity sounds like something out of Blade Runner or The Matrix. But in reality, it is something that happens all the time in neurosurgical centers throughout the US and throughout the world, because it's a very useful clinical technique for diagnosis and treatment of a variety of disorders, right? So that's kind of the way in. We have patients, and kind of the most common examples are patients that have epileptic seizures, which are not well managed through medication. And so their only option becomes surgical, because if we can identify the part of the brain that's malfunctioning and it's generating these seizures, we can treat that. We can isolate that part of the brain. We can put a stimulating electrode, which we'll talk about. We can even cut it out in a way that's very carefully designed to not cause any deficits. And that actually has a very good chance of, in this case, curing the patient, right? So in essence, there's these really strong drive and need to use these surgical approaches to treat different patient populations. And there's others. There's Parkinson's disease, dystonia, movement disorders. We talked about epilepsy. And then there's increasingly a use for psychiatric conditions, which is something that no doubt we're going to go into. But the notion is that we're bringing these patients for safe and effective treatment and diagnosis of their disorders, but also from a scientific standpoint for someone that cares, like myself, about understanding how the brain works. It opens up a phenomenal and really unique experimental opportunity, right? We're bringing these patients in and we're having these surgeries and we're implanting these electrodes. In some cases, it's a kind of a relatively short implantation of a few days. In some cases, these are chronic implantations, meaning the electrodes are implanted for a long term, and the patient goes back home and they keep these electrodes in their head because that is how the therapeutic is delivered. And then at the same time, we can record the electrical activity from all the places where these electrodes are positioned in a way that's otherwise not feasible, right? Because it's not ethical to do these things for purely research purposes. But what we're doing is adding a research layer on top of an already existing clinical intervention. And suddenly, boom, you can record electrical activity from deep in the brain of a human that's living and breathing and has, the ability to do many, many phenomenal things and engage in all these cognitive processes. And we can talk to them. They can explain how they're feeling. Right. So in a sense, it's kind of a dream scenario for a cognitive neuroscientist because you get access to extremely high quality data from deep inside the brain in a way that's usually not possible in human patients because we have to normally do our research without implanting electrodes. We use scanners, right? Magnetic scanners, fMRI. We use non-invasive electrical physiological recordings like EEG, or we revert to animal models, right? Where we have a lot more control. But of course, there's also some limitations of those because, animals are different from humans in many different respects. And sometimes we have appropriate disease models that we can study, for example, in the rodent. And sometimes those models are not that great at recapitulating what it is that the disease does in a human being. And so we live at the intersection of, the really high quality data that's normally limited to animal models and the phenomenally powerful ability to work with a patient who can express what they're doing and they can do all sorts of different things and they can communicate. And yeah, it's really an amazing opportunity.
Oh my gosh, yeah, I completely agree. And I'm just thinking like an animal, like a little mouse or something can't tell you, hey, I feel depressed today. Hey, I feel suicidal. Like those are all things that your lab is really on the forefront. And I use functional MRI or functional imaging in my research. And you hit it exactly on the head that these techniques that we have are so limited and we're making these, really imprecise inferences about what's happening in the brain. And you're able to leverage this really unique, as you say, like people coming in for these treatments to have really unique insights. So I just want to underscore like how cool that is. And it does sound science fiction.
It's just, I feel very, very lucky to be able to do these things. It also is kind of part of my lab's DNA that we're right there at the clinic, right? And that has an additional side benefit, which is we're constantly reminded of the need, right? The clinical need that these patients have for us to
Right.
understand the disorder, create new treatments. And so we're very close to the human component of things, which
Yeah.
is, I find very, very valuable.
Absolutely. Yeah. Thank you so much. And I want to talk specifically about depression, which is one of your research kind of areas. And it's such a common disorder. And, it's comorbid with things like epilepsy, which you mentioned. And, I think in the kind of the lay public, it's often characterized as like feeling sad or a chemical imbalance. But I want to know from you, the expert, like what's actually happening in the brain when someone has depression?
Yeah, so we have a partial picture of exactly what happens in someone's brain, right? And so that's that incomplete understanding is one of the reasons why we don't have a fully effective treatment that will cure all of our patients with depression, right?
Hmm.
So I think that some of the gaps that my lab is trying to fill in is in trying to understand at the biological level how the brain from a depressed individual is different from the brain of a non-depressed individual,
Hmm.
right? Like we talked at the beginning, the reason to implant these electrodes and do these surgeries rarely is depression itself, right? I mean, there's some
Hmm.
clinical trials and there's an increased interest in developing new treatments, but those are very, very rare.
Hmm.
But there's other opportunities, and this is kind of one of the characteristics of this type of research, which is really opportunistic. And the opportunity in this case is that the epilepsy patients that come in through our neurosurgical program, and that happens a lot because there's a large number of epilepsy patients whose disease can be managed through these surgical implantations.
Hmm.
A large proportion of them suffer not just from epilepsy, but also from depression, right?
Hmm.
30 or 40% of our epilepsy patients are also depressed. And then,
Wow.
60 to 70% are not depressed, right? So
Right.
even though everyone has epilepsy, now you have the ability to compare two brains that are built differently,
Right.
right? One of which has depression on top of the epilepsy and one which doesn't, right? So that kind of contrast is within the limits of what we can do on the surgical world, very, very valuable, right? Because we
Absolutely.
can basically try to elicit some of the symptoms and behavioral characteristics of that we think are going to be different in a patient that suffers from that comorbid depression than a
Right.
patient that doesn't. And then we can open up the brain and we can look at that electrical activity
Literally.
in the different brain areas and say, okay, when that happened, how is this different from that? And in combination with the detailed, fast that we're measuring electrical activity many times per second in
Hmm.
hundreds of brain sites at the same time. So the picture is really very comprehensive and very detailed. So we think that that's going to allow us to, determine to some extent what is it that makes a patient respond differently
Hmm.
to, you mentioned reward, which is a central part of the lab, to reward than the patient who is not also depressed.
Yeah, and you said at the outset that we have kind of an incomplete picture. So I guess at this point, I know what you're doing is, on the forefront, but what would you tell somebody if they were like, okay, how do you describe the biological basis of depression, at least what we know
Right.
right now?
Yeah. So, well, the first thing I would say is that we use these big buckets to characterize mental disorders, as
Hmm.
you know, and they're used because they're useful in clinic to make these classifications and to initially orient practitioners towards a treatment or another. But we know depression is not just the one thing, right?
Right.
Many different variants of depression. There's a whole constellation of symptoms that people with depression suffer, and everybody has kind of different combinations of symptoms, right? Someone might be really low energy. Some other person would have, this really acute feelings of low self-esteem.
Hmm.
Some others will be just engaged in this ruminative process where they just can keep thinking about bad things that happened in the past and so on and so forth. So people with depression have different combinations of these symptoms, and that's a clue that their underlying changes in their brains are probably also different,
Hmm.
right? And so this is something that is kind of a more modern conceptualization of these and many other disorders, that they're not monolithic. There are a bunch of disorders that have common threads and common characteristics that
Hmm.
have helped us quantify them as one. And then, of course, that's useful clinically, but we know that is incomplete.
Right.
And that is incomplete because we're not capable of treating everyone, right? So another side of this kind of monolithic approach has been when we treat these disorders, for example, with drugs, right, with pharmacological approaches, people with depression oftentimes try SSRIs, which are drugs that are designed, they affect the serotonin receptor, the serotonin reuptake proteins in your brain and kind of raise serotonin levels, which has led to this concept in, popular culture that low serotonin equals depression, which we know is an oversimplification, but it is in some part derived from the fact that we think of depression as one thing, right? It's probably a lot more detailed than that.
Right.
So more recent efforts have gone in the direction of, okay, well, if it's not one thing, how many things is it, right?
You're
How
going
many
to be employed for a long time. It's
Well, so hopefully not, right? Hopefully we make great strides and we don't need
Yes.
to think about these problems anymore. But the idea is that, okay, if we, instead of thinking about these from the simple symptomology aspect, right, which is a very natural starting point when, a patient who suffers from this devastating disorder comes into the doctor's office, as scientists, we can start thinking about the underlying biology, right? What is the biology and how does it drive the behavior? What is different between a depressed and a non-depressed brain? I already introduced that idea, but of course, that is also an oversimplification because there's going to be probably different subtypes of depression. Can we characterize those? Can we look at those? Can we somehow take some sort of measurement or do some sort of task or test that allows us to, take a patient and say, okay, well, you're subtype A and subtype A requires treatment A, or you're subtype
Right.
B and then we require treatment B and C and so on. Because so far, unfortunately, the prevailing way of, trying to improve someone with depression is trial and error,
Yeah.
right? And that's just the best we have at this point. And there's a growing understanding in the scientific community that, well, I mean, obviously that's not good enough, right? Because it's additional time of suffering and frustration for patients, and they can't find, and maybe the right drug is out there, and you just need to find the correct SSRI that will treat you. So that an intermediate step in doing that is thinking, okay, what type of depression are you suffering from, and how do we match you to the best trial type of treatment, right? So that requires a change in how we think about it by defining subtypes. So
Right.
unfortunately, there's already been strides in that direction where we can actually say, okay, well, there's different types of depression that can be conceptualized differently. And of course, if you take these logical progression to the extent, everyone's depression is different.
Yeah.
And everyone's psychiatric condition is different. And so can we do these on a patient by patient basis? Can I study someone and say, okay, well, you have your own type of depression, which is characterized by these specific deficit. In neuroscience, when we think about these deficits, we tend to use the word biomarker, meaning what is the one thing that I can measure in your brain that tells me if you're A or B, right? In some disorders, we have clear biomarkers, right? So, for example, if you think about some neurodegenerative conditions like frontotemporal dementia, you can put someone in an MRI scanner and you can clearly see the difference between a brain with dementia and a brain that doesn't have dementia because their brain is shrinking and you can tell that the gray matter is becoming thinner, and especially in the frontal areas of the brain. That is great. That's what we need as a diagnostic tool and maybe as a way to, suggest types of treatment. But when you do that in a psychiatric patient, you don't see anything. That's part of the challenge, right? There's no image that will tell you, oh, you are suffering from depression. The kind of thing that I do is not so much predicated on image, it's predicated on activity, electrical activity, right? And the idea is that the biomarker idea also applies because can we look at that electrical activity that's in area A or B or C and find some sort of pattern of activity that differentiates, right? So the biomarker idea is very flexible. And of course, if we get that, well, that's a way in. That's a better way of conceptualizing what is different in your brain.
Absolutely. Yeah. Thank you so much for painting that picture. And it's happening in all of psychiatry, as you kind of alluded to, that we think of like schizophrenia, for example, as one kind of uniform condition, but there's actually different like biological subtypes which is why what you're doing is amazing. And I think people will kind of get the analogy between depression and, like, I think of cancer. Like, there was all like this movement like, oh, we're going to cure cancer. And then it turns out that there's thousands of different types of cancer. So there's not like one cure. So I think same with depression. That was a really nice way to paint the picture, and that you're looking at biomarkers and electrical activity of the brain, which could hold the key to, we can't look at an MRI scan and see like, oh, there's depression in the brain, right?
Yeah, or maybe you can. I mean, maybe there is a way, and there's also exciting developments in that arena.
For sure.
Maybe we can, and that would be ideal, right? Because you don't want to have to stick an electrode in someone's brain just to diagnose. Although we'll do it if we need to, right? This is what happens with epilepsy, right? If the need is really dire, and the method is really true and tested, yes. But of course, we want to do this in a non-invasive way. So if we could take a picture of your brain and say, look, and again, there's exciting developments in that direction with imaging too.
Yeah, and I think your work will help guide that work. And we just heard from Amanda, whose depression was so bad and treatment resistant. She did the trial and error. She was suffering for decades, and she resorted to surgery to have deep brain stimulation. So certainly there's a need for that, and people that are willing to do that, which sounds extreme, but if you're out of options, right?
Yeah, I mean, and they're pioneers, right? And it's these really close relationship that we build between the clinical teams and the research teams and the patients who are brave to do these things. But it also speaks to how dire of a need they have to do something about their condition, right?
Absolutely. Yeah, and I do actually want to pick your brain about suicide, because that is, as you said, like one of the most dire needs we have in psychiatry, and we don't have great treatments. And, I do just want to say that there is a helpline available for folks who are suffering. You can text 988. That is the National Suicide Hotline at any point. But Ignacio, I want to pick your brain about these really frightening symptoms that can appear in severe depression and other disorders. So from more of a brain science perspective, what do we know about when someone reaches that point? Like, what is happening in the brain of someone who's experiencing suicidal thoughts or behaviors?
Yeah, it's, depression is a terminal illness, right? When you think about how likely someone with deep, severe depression is to try to commit suicide. And so that is very, very sobering thought for those of us who work with, these disorders and these patients also, right? I would say that, from a cognitive neuroscience perspective, mood is kind of the first thing that comes to mind when we think about depression, right? You mentioned this, you're super sad and you're just in this deep hole of sadness, and but there's also all sorts of cognitive distortions that come with it, right? That's where some of the work that we're doing helps. So, for instance,
could you say more about what do you mean by cognitive distortions?
Yeah. So, for example, we talked a little bit about the different symptoms that patients have, right, or the depression patients have. One thing that we in my group have cared about is this idea of rumination. Right. And rumination is the tendency that some of these patients have to kind of get stuck on bad things that happened. Right. And, this bad thing happened. I just can't stop thinking about it. And, what's interesting is bad things happen to all of us. Right. We all have, uncertain things. And then suddenly, something bad happened. You lost your phone or your grant was not reviewed.
Or someone erases your whiteboard behind you. It's beautiful for those watching the video.
My thinking goes away, right? And then there's a very fundamental superpower that humans have to think about what could have been, right? And that's from the standpoint of learning, how can I do better? And the next time that I'm faced with this situation, what should I do? That is phenomenally powerful, because it means that you learn not just from the things that you experienced, but also from the things that you did not experience. That's the good side of things, right? Yeah. The bad side of things is, what if that whole process, that imagination, counterfactual thinking process goes awry, and then you get stuck on the bad thoughts only, right? That is one way to think about this rumination characteristic of some of these patients, right? So they're not experiencing reality in the same way that someone who doesn't suffer from depression does, right? they can be stuck in those negative loops of like, doom and despair. It's like, oh, I should have,
Right.
right? So it's kind of the double-sided coin of, you know, the ability that human beings have to imagine and think about things that did not happen and things that are very valuable from an evolutionary standpoint, but they come at a price.
Mm.
And in this case, the price is that system can go bad, and that leads to some of these deficits that we see in depression, right? So at the extreme, that can lead to thoughts of suicidality because you think everything is bad
Mm-hmm.
and you're in a really bad space and everything that happened before is bad and everything that's coming down the line is also bad, and then this dread about the future too, which is characteristic of depression and anxiety. And so you get a very distorted view of reality in your
Mm.
head, not through anything that's your fault, but because of the changes in your brain that make you feel that way, right?
Right.
And that's what we think leads to, these escape and this idea that, maybe I should just, you know, stop with the
Right.
suffering, stop with these things, right? We take it very seriously. I mean, in my lab, fortunately, we live in a very clinical environment, so we have protocols in place
Sure.
when we're working with patients who suffer from depression, especially those that have severe depression. There's all sorts of mechanisms in place where we can alert the clinical team if we think a patient has, suicidal thoughts and so on and so forth. But that's the best case scenario
Right.
because we're at the hospital where there's tons of support and we can act quickly and rapidly. But, these patients are living their lives, right? And
Right.
they're suffering from these low mood, these distorted thoughts that make it's just like having black tinted glasses, right? And everything looks awful.
Yeah. No, and thank you for painting that picture. And I love how you pointed out that like this unique capacity of the brain is, it's extraordinary in some ways and it's very helpful and it can go awry. And I think that's true for a lot of, what we study in human behavior, right?
Yeah, and that's a very good point also because we talked a little bit about the power of using these surgical approaches in human volunteers
Right.
versus the animal models. This is something that, presumably animals can do to some extent, imagining what would have been, probably not as well as human beings,
Mm.
but it is just so natural to us. It is
Hmm.
just so natural. We cannot help but think about, oh, maybe I should have done the other thing, right? And not only that, but like you said, it is very, very accessible for study in a
Hmm.
research environment, right? Because you can just tell me, I can ask you, hey, what were you thinking when you were doing that thing? What
Right.
was going through your mind when you saw that picture? What was your rationale for taking that course of action? Those are, very extremely simple to implement because we can just
Right.
ask patients, but it's extremely valuable. It's one of the first things that when I ask my colleagues that work with animal models, what would you do if you could? And 9 times out of 10, the question is, I would ask them, what's going through your brain right now, little rodent? Like,
Right.
why are you acting like that, right? And we have the privilege of doing that,
Yeah.
which gives us a unique view at, brain activity.
Oh, absolutely. So beneficial. Yeah, thank you. I want to move and switch gears a little bit into treatments. And you already painted a really nice picture for why, a third of people, give or take, don't respond to antidepressants like SSRIs. And I want to talk about how your research fits into that. And you're doing some really cutting edge work, on the frontiers of actually leveraging brain activity and targeting it for different conditions like depression. So can you tell us more about neurostimulation and what you are doing in that space?
Absolutely. So, like you said, with our like our battery of drugs and cognitive therapy and all the different things that we know can help patients, there's still 30% of a very large patient population that doesn't respond to treatment,
Hmm.
right? So immediately the need is obvious. We need new treatments. We also need prevention, but we need new treatments for those patients who are what we call who suffer from treatment-resistant depression,
Hmm.
right? So we call it TRD. And the idea is that there's got to be another sort of way, and I'm talking about kind of three ways is how I like to think about it. One is the kind of cognitive therapy, counseling, kind of reorienting of your own thoughts type thing, which is very effective for some folks. Then there's pharmacological treatment, which is, we have a different array of drugs and the matching is difficult, like we said, but, a lot of people respond to Prozac or other antidepressant drugs, and that's enough for them. And then there's the unfortunate 30% who don't respond to anything, right? So what do we do? What I think my answer to that is we need new treatments that use a different set of methods. We don't need another type of drug.
Yeah.
Why? Because we've talked a little bit about the heterogeneity in symptom presentation and how that's probably related to different subtypes of depression. At the extreme, every depression is different, right? So how can we hope to treat such heterogeneity with a one-size-fit-all type of approach? How can I just say, I'm going to give you this one drug that affects this one type of receptor that's all throughout your brain, and then it's going to work for everyone?
Right.
It just doesn't. We know from experience it doesn't. And we think that the reason is because it's not one size fits all. We need different approaches to different people. And I mean, granted, if you can solve it with a pill, that's phenomenal. All the power, it's great, right? Because you don't have to go through surgery. But if it doesn't, then we need a bit of a change in how we think about it. And my thinking is that the key is in that heterogeneity, which exists not just at the symptomology level, but also at the biological level. Right. So the fundamental idea is that when people manifest different combinations of symptoms, that probably reflects that there's different brain areas, to put it simply, that are differently altered in different people. And we have a number of suspect brain areas which come from animal research and from fMRI research and a bunch of areas that we think, okay, well, these are culprits, these are suspects, right? And so maybe we can find out, on an individual basis, which of these brain areas is malfunctioning for you, right? And then we can think about how to modulate them, right? So instead of using a pharmacological approach, it gives you a pill that, blocks your brain with serotonin or whatever, we can actually go in a more surgical way, pun intended, and finding what is the brain area that I really need to modulate in your brain, but not in someone else's brain, right? There's pioneering work that's been using deep brain stimulation, which is another surgical approach. Maybe now it's a good time to introduce it.
Yeah, that'd be great.
Yeah, it's think about it as a pacemaker for your brain, right? Imagine fairly well what brain area is suspect on an individual, and you need to modulate that without affecting everything else, right? That is where the side effects of these drugs come in, right? Because you're hitting not just the area that malfunctions, but everyone else. Suppose you want to be just at one side. Deep brain stimulation gives you a way to do that. We can implant these electrodes deep into the brain of patients, and then we can implant them chronically, meaning once the surgery is over, the patient has an electrode implanted permanently, and then they also have a little cable and a battery that is constantly delivering a little bit of electrical stimulation, just safe levels of electrical stimulation for the duration, right? For weeks or months or years. This is a treatment that also sounds a bit like science fiction, but there's hundreds of thousands of patients that have been treated with this approach, specifically or most effectively for Parkinson's disease. So Parkinson's disease patients that, Parkinson's is a neurodegenerative disease, which means that it progresses through time, right? And at some point you can treat these with a pill, and at some point you have to up the dose of the pill to the point that you start inducing these side effects, or it's just not effective, and then DBS, deep brain stimulation, becomes a surgical strategy that works really well. So you implant this electrode deep in the brain, we know exactly where to put it, you deliver the stimulation, and it doesn't cure the disorder, but it gives you phenomenal relief from the symptoms, right? So the first thing that comes to mind when you think about a Parkinson's patient is like they're rigid, they have this tremor, and those can be really alleviated with the surgical intervention. It's kind of overnight. It's magical to see, right? Because you talk to these patients, they're typically older patients in the morning, and they take them off their medication, so they have this tremor and they're visibly, affected by the disorder. And then in the evening after the surgery, their tremor is much better, and they can tell that that's kind of a chronic, and then there's an acute, and then there's a chronic component to how we see these things. But it gives you immediate relief from the symptoms. It's really
amazing.
amazing to see, right? And so
Yeah.
we have this method. We know it's useful in this set of disorders, which are primarily neurological disorders, for which we have a better idea of where to put the electrode. And now there's kind of a whole array of labs and researchers that are interested in thinking, okay, so we have this method. Can we use it for other things that are not just movement disorders? Can we use it for psychiatry?
Right.
Right? And that's yeah, why shouldn't we, right? And one of the difficulties is that, well, we need to know where to put the electrode, right? And we need to know how to stimulate it, and we need to characterize you on a personal level. And so in my lab, like we talked about, with these epilepsy patients that also suffer from comorbid depression, we get access to many different brain areas. And we can record for them for days. And we can ask the patient to, for example, engage in games and tasks that are going to force you, for example, to experience bad things, like little bad, not bad, bad. But I'm going to have you play a game and maybe, you flip a coin and you lose. Well, that's a bad thing, right? But, to a healthy individual, that's like, okay, fine, I'll move on. But not to the depressed individual who might be, stuck on that rumination, right? So can we find where that rumination lives in your brain? That's the fundamental idea behind some of the experiments that we're doing, right? Can I have you play a game where these mini bad things happen, and then the hypothesis is that when a bad thing happens, if you happen to be also depressed, then you're going to get stuck on it, and then we're going to be able to see a brain area that acts differently than that of a brain of a patient who doesn't have depression, right? That gives you the location, and now you have total flexibility. Because it could be one brain area, it could be another, it could be another. We know there's many. There's the anterior cingulate cortex, the orbitofrontal cortex, the amygdala, many brain areas that we know are involved in depression and in this type of behavior. And now we have flexibility to say, okay, I can stimulate this area or that area or a combination of two, and so on and so forth. So it's a thorny problem because there's many potential combinations and so on, but the fundamental idea is that we can optimize on a patient-by-patient basis. And we can find treatments that are anatomically precise in a way that drugs are not.
Right.
And so that's the promise behind this whole neuromodulation approach, that we can do things with more specificity and optimize them at a more personal level. And that hopefully is the third therapeutic way that adds to our arsenal of, cognitive therapy, pharmacology, and now neuromodulation.
Yeah, it's so amazing to hear you talk about just like the personalized aspect. And, we had John Nelson and Amanda Geisinger on the podcast, and they have basically had their lives saved by this treatment of deep brain stimulation. And it was like instantaneous, as you're saying. So it's just crazy to see that you can just, implant that electrode in their personalized brain region and have like immediate relief. Like that does sound science fiction, Ignacio.
Yeah. I mean, it's all part of the plan, right? I mean, right now
I imagine you going like this. It's all part of my evil plan. No, your human saving plan.
I mean, this is the thing, right? We have this method, it's safe, our surgeons, our experts are deploying it, and it's extremely effective in a small set of conditions. And I think it's kind of up to the researchers and those of us who are in this space to say, okay, well, you know what? You have that really cool hammer. I'm going to give you a bunch of nails.
Yeah.
Right? I'm going to give you a bunch of disorders for which this is effective. And suddenly, boom, there you have it. You have patient impact.
Yeah.
And what's interesting is that the need is there. The knowledge to do the surgeries is there in terms of implanting the electrode in X, Y, or Z area.
Yeah.
What we're missing is that biomarkers, like, having a protocol that's derived from scientific knowledge that says, here's the place for these patients, you put it there.
Right.
Done. Right. And so that's the roadmap. John and Amanda, they have their electrodes implanted in the same brain area, which is kind of pioneering work that was done 20 years ago by Helen Mayberg. And that has been polished and fine-tuned to also optimize on a patient-by-patient basis to really carefully insert the electrode in the exact spot.
Yeah.
And it's unbelievable how precise it's gotten and how sensitive it is to just a few millimeters off.
Wow.
And so, those are kind of the ideas that we're building on, right? Can you optimize on a patient by patient basis? Can we do things that give us new avenues for treatment for disorders that need them using tools that are already existing and somewhat standard in neurosurgical settings.
Wow, yeah, and just the level of precision you pointed out is extraordinary. Well, I'm super excited to see what you do. I have a couple more questions, and I feel like these could be their own hour conversations. But this is such a hot topic right now. We keep hearing about psychedelics and ketamine. How do those techniques fit into the three kind of buckets you mentioned and your own work? How are you thinking about those?
Yeah, they're new, they're all the rage because they're effective, and I'm so glad to see that we're kind of moving past the stigma
Mm-hmm.
of some of these drugs as party drugs or whatever, because they really have therapeutical advantages which are really amazing. You could either group them in group two, right, with pharmacological approaches, or maybe even make them a separate thing because they're really outstanding in how effective they are when they are effective. And sometimes it's like, a single dose will really reorient your mind. So
Yeah.
that also fits in group one. I'm not sure. But it is very exciting to see that there's these, easily deployable, that if you do this properly, it's really safe and it really helps people turn around in some cases. From my perspective, there's work going on in my field where people are trying to combine the two approaches, right? In other words, we know that by giving you psilocybin or a different psychedelic, something happens in your brain that in best case scenario turns you around and you don't suffer from depression anymore, right? Can we combine that with the sort of really high quality brain recordings that my lab does to know exactly what happens in the brain when you give someone psychedelics? There's research that's already happened in that direction in Stanford, and there's a lot more to be done, because if you have something that's very effective at the clinical level, but you don't understand it from a biological standpoint, it's also a unique opportunity to go and say, okay, you happen to have these electrodes implanted. I'm going to give you, a dose of this psychedelic. What happens in your brain when things shift, when you feel different, when your mood is elevated, and so on. Now, this is not easy, right? I mean, it's complicated because it requires very careful coordinator or coordination of different surgical and diagnosis and so on and so forth. So it's not easy, but as an idea, that's how I would leverage that to better understand when we get these hugely massive positive impacts of delivering a single dose or a bunch of doses of a psychedelic that has this great positive impact. What exactly does that look like in the brain?
Yeah.
And that could inform all the neuromodulation approaches, because if these way of shifting from depressed to non-depressed is manifested in the brain, well, that gives us a clue that we can use with a different patient population, regardless of whether they're going to be taking psychedelics or not.
Absolutely. Yeah. So much potential. And we definitely need to get you on the podcast again when you've done those studies.
We'll do a part two. That's right.
Oh
Yeah.
my gosh, it's so
Yeah.
cool. And I mean, what you just said is so amazing, like a 1 or 2 dose versus what you said at the outset that people take SSRIs. It's trial and error. It takes months to years to find a treatment that works for them if they ever get that. So really, really promising. Yeah, I'll definitely have
It's
to have you
exciting.
back.
I'm not an expert in that, but I am keeping track of it because it's amazing to see
Yeah.
how much it's grown and how much promise exists in
Oh,
those
yeah. And
treatments.
as you said, how much promise your set of techniques and approaches could inform that, which could have really broad implications. So I'm really excited.
Everything helps, right? I mean,
Yeah,
it's always going to be a multifaceted approach and
exactly.
a multi methodological way of looking at these.
Yeah,
And that's what we're doing. Yeah,
exactly. Team science. Absolutely.
exactly. Team science, go.
Yeah, yeah. Okay, great. Well, I want to close by just having you say, like, if you wish people could understand one thing about depression, or if you have someone who's suffering or has a loved one, like, what would you say to them? What would be your thoughts?
I would say that people need to understand that depression is not just being sad, right? It's very natural to conceptualize it as part of our, human experience, but it is a worst case scenario of really debilitating disease, which has a biological basis. The brain of a patient who suffers from depression is not the same as the brain of a patient who does not suffer from depression, right? And you're not guilty. It's not your fault that you're suffering from these things. You're not responsible. And we really need to understand that and kind of, like John would put it, cross the stigma, right? And say, these patients are suffering from this debilitating condition because their brain is changed. How can we help them go back to a healthy state? And there's no shame in it, and there should be no judgment associated with it. We just need to be compassionate and understand that you don't get judged if you break your arm, right? Everybody understands that something bad happened to you and you went through this traumatic thing and then you need to heal, right?
Exactly.
Why shouldn't we think about depression in the same way, right? There is a broken bone somewhere in your brain,
Exactly.
right? We just need to find it and cure it and bring you back to health. And there's no shame in that.
Absolutely. Compassion and pulverize the stigma. I love it.
There you go. There you go. Full
Ignacio, thank you so much for joining us today. Your work and your team, everything you're doing, recording from that living human brain to understand and treat depression and a variety of other conditions is truly, truly remarkable. And just on a personal level, just the care you bring to the science and to your work and the patients who are suffering it really is thoughtful. So thank you.
Thank you so much. It was so fun talking to you. I hope we
Yeah.
can come back for a part 2 at some point.
Oh, definitely put that in your calendar. And then for listeners who do want to learn more about Ignacio's work, we'll have links to your labs and publications and your awesome social media. That'll be in the show notes today. And then if this episode resonated with you, please subscribe, leave us a review, and share it with someone who you think might benefit. And then we are on social media as well at BrainSTEM Podcast. Thanks again, Ignacio.
Thank you so much, Hilary.